Okay, it is August 17, 2023. We're here at the Duke Spine Institute broadcasting live spine surgery. Our patient has 2 bad discs in his lower back, and actually he has 4 bad discs in his lower back, but 2 that we'll be fixing today. He also has facet joint pain, but we're not going to be addressing that. We're only doing the discs. The bottom 2, L4-5, L5-S1. He's hoping to get some good relief from his back pain. I expect that he will. Shot. All right, 5-1 is traditionally, has always been the hardest disc to get to. And that's one of the ones we'll be doing today. Shot. You can see the needle on approach, approaching the facet. Shot. That facet is big. That's not normal. Shot. That's right. I got to work my way around it, which I've just done. Shot. I could feel the last of the facet. There we go. Shot. Perfect. We are there. Let's get an AP and see where we are. So far we've lost a drop and a half of blood. The Duke laser disc repair, which we're performing today, is relatively bloodless surgery. Perfect. Is he reliable? I think we're all right. Yep.
Hello, my friend. Can you open your eyes for me? Right there.
No problem. We're good. Shot. I feel the herniation. Hold on. Oh, huge facet. Huh? I think there's something on the fluoro. We're going to adjust the fluoro. It's very important your fluoro is lined up properly, because that way you can have reliable information. That looks like I'm a little high. Shot? It's a little blurry. There we go. Maybe I'm a little high. When I say high, I mean high on the X-ray. I don't mean I'm actually high. High on life, perhaps.
Say you're north.
Yeah. Shot? All right, so we are here once again. I think we're off on orbit. We are off on orbit. We're about 1.5 degrees off on orbit. Shot? That's, I think, better. Maybe, or worse. Actually, I think it's worse. It is worse. Sorry. That's better. All right, that is better. Let's leave it there. I think that's as good as we're going to get it right now. I still feel bone. Shot? I think I'm just really low in the framing then. They call us needle jockeys because we got to jockey the needle. What we're trying to do is get the needle into the disc space where it belongs. Let's go for the next one. I'm going to make my incision. Our patient is asleep. I've done a 7mm incision. The whole surgery will be done endoscopically through a 7mm incision. Shot. Perfect placement. Shot. Shot. Very good. Interesting. Let's take an AP. We're going to use another view called AP, which is a front-back view. Let me know when you think he's ready. It's nice.
My friend, you okay? Yeah. Can you open your eyes? Thank you. He is following commands.
Wonderful. All right. So we know from where he told me he had pain that his pain is coming from at least 2 discs, probably 3. We're going to fix the bottom 2, the L4-5 and L5-S1 today. He also has facet pain, but we're just fixing the disc today. We're going to stay focused on that. All right. Are you comfortable?
Any pain, sir,
Shot.
in your back? Yes or no? No pain.
All right. He has no pain.
No pain.
Yep, that's what we want. We want no pain so we can determine if these discs are causing pain. And the way we do that is we use an old test called the discogram. Are you comfortable? See him jump?
Yep.
You see him jump? How bad is that on a scale of 1 to 10?
Give us a number.
How high does it go?
What number? Couldn't hear you.
How high does it go?
10?
10.
3 or 4, as you said.
No. There's no way. He jumped off the table. You comfortable?
Are you all right? He said yes. He said yes.
You awake?
Yes.
All right. Are you having any pain right now?
You have any pain right now? No.
Look at him.
Give us a
How
number.
bad is that on a scale of 1 to 10?
Is that a 10? What number? 2.
Is that where you typically get your back pain?
He said yes.
All right, we got to put him back to sleep. He's not very reliable, but he did say that's where he gets his back pain. He called it a 2, but he almost came off the table, so clearly not a 2 according to anyone else's numbers, but we got what we needed, which is that's where his pain's coming from. We're going to start with the L5-S1. Shot. You're doing great. Just count out loud. All right, let's show our audience, Sanjay, why do discs like herniations, why do they cause so much pain?
Copy that.
All right, welcome back. We are placing the tube in the first disc that we'll be repairing, L5-S1. The tube is the endoscopic tube. Shot. Looks good. Luis is removing the dilator. Now we have a tube. This tube is 7 millimeters wide, and the tube is where we're going to do the surgery, through the tube. Because the tube is so small, we don't have to open the patient up. And the tube doesn't cause any damage to the patient's body. like open surgery. Microdiscectomies, laminectomies, very destructive. Old-fashioned surgery. You don't want it. So what I'm seeing is a lot of inflammation in this disc. You can see that right there. Grab her. The inflammation is called discitis. It's not an infection, it's inflammation. And that's what causes so much pain in people who have a herniated disc. The herniation makes inflammation. The inflammation makes pain. A lot of people don't know that. A lot of doctors don't know that. Doctors seem to think that what causes pain is a pinched nerve. But a pinched nerve never causes pain in the back. It causes pain down the leg. It causes weakness in the leg, but never back pain. All right. We're going to bring the laser in. Any questions from the audience?
No questions?
And you are broadcasting, right?
Yes.
All right. Have you checked the laptop with the feed to make sure it's coming?
I'm in the room. I'm checking on YouTube right now. We're all good.
All right, great. Thank you. Grab her. So you see the end plate there on the side and the annular tear. You know what's shocking is, may surprise you, neurosurgeons and orthopedic spine surgeons, they don't ever do this surgery. They don't know how to do it. It's a new technology, but it's been around now for years, 20 years. And they just never learn it because it's not taught to them. It's not taught to them because their education is controlled by companies that sell screws and rods, not scopes. And because their education is controlled by the companies that sell the screws and rods, these surgeons never learn the less invasive treatments. They go after the treatments that pay the biggest amount of money to them and the hospitals and the companies that sell the screws and rods. Think about fishing. Is fishing good for the fisherman? Yes. Is fishing good for the boat owner? Oh yes. Is fishing good for the industry? Yep. Well, what is fishing not good for? The fish. Damn right. Well, the patients are the fish. And you guys are all getting screws and rods and laminectomies and microdiscectomies done.
You're all getting catfished.
You're all getting catfish. Well, I don't even know what catfish means, so.
I saw a lot of catfish the other day. Too many.
You caught a lot of catfish.
With my son, I was fishing. Catfish, the social media term.
What does it mean?
Kind of like bait and switch.
Really?
That's
Bait and switch.
Yeah, if you want to make it analogous to another fishing term.
I didn't know that.
Same
Grabber.
Same thing as
We're done here.
only it's more for dating.
Catfish?
Switch is more in the business world and catfish is in the social world. Best way to
Really?
describe it.
I don't understand. Is it like when you put a fake picture of you?
Yeah, that's catfish.
Oh, I see. Well, I don't date, so. Huh?
Like me.
All right, we're done.
I know it from my kids.
Scope off, thank you. So that's one down, one more to go. And Sanjay, we've shown both educational videos or just the one?
Just the one.
Let's do the one that shows how the Duke laser disc repair works.
Copy that.
Welcome back. We have finished the first disc, and now we're working on the second one. Shot? All right, very good. Yeah. I may need that guide wire out soon. Give me a second. Shot? Let's take it out. All right, so we've got one disc finished. The other one we're entering now. We're placing our tube. And this is called a tubular retractor. It retracts the tissue, and it's a tube. There are different kinds of retractors in surgery. Some are round and some are linear. There's all different shapes and sizes. Come on out, Jordan. But for endoscopic surgery of this type, the tubular retractor is the best. "10 minutes, Dr. B. Grabber. Now this disc is a fresher herniation. Luis?
Yes, sir.
Oh, is that just bag suction? Any questions from our audience? Yeah, you can tell this is a newer herniation
No questions?
just by what the disc herniation looks like. Boy, it looks real different than the last one, doesn't it? The last one just had the bone end plate and that was it. This has a lot of herniation. And I shoved it back into the disc with the dilator. And this is it right here. We're getting it out. There's another piece. See how nicely the laser just cuts these things in half. If I try to do this with the grabbers, the metal grabbers, it doesn't work. By the way, we call those grabbers pituitary rongeurs. And they work fine for pulling things out. They don't work fine for things that are scarred down. And these herniations are all scarred from inflammation. Again, this is something that we figured out at Duke Spine. The rest of the world hasn't figured it out yet. So, unfortunately, doctors are still recommending the old spine surgery treatments. Microdiscectomies, laminectomies. They don't understand the pathophysiology of this disease. It's an inflammatory problem. It's always been. Back pain has always been an inflammatory problem. It's just, huh? Yeah. Inflammation, true. Like we didn't even know cardiovascular disease was inflammatory. Now we realize it is inflammatory.
They even have tests now, cardiolipin test. They have all these different tests to check how much inflammation you have in the
Yeah. I think the problem is our inflammatory system is an old system, but it's outdated. And we still need it, obviously, to fight bacteria, but it does a lot of harm. Like I just had a virus infection, right? Viral respiratory infection. The virus was bad, but what happened was the virus destroyed my inflammatory system destroyed my pharyngeal tissues, my nasopharyngeal tissues. And now there's no tissue left because the inflammatory cells came in and attacked everything. So I have this dead mucosa that is, physiologically dead and susceptible to bacterial overgrowth. So you get what's called a bacterial superinfection over the virus laying yeah, it's very common. And nobody really understands that. Very few people understand that. Oh,
That's related to the virus triggering the inflammation.
yeah.
And the cilia and your respiratory tree. But your respiratory tree has its own immune system.
Yeah, of course.
The immune system's damaged.
Yes. The immune system's damaged, but the inflammatory system is what destroyed it.
Because it's overregulated. So
It's just over-revved. It did too much. It's just a virus. Leave it alone. It'll limit itself, right? But the inflammatory system came in and just destroyed everything. Now, there's probably there's a protective mechanism there we don't understand. It could be related to the virus wants to take over cellular machines, right? They want to take over your cells, DNA and RNA, and start manufacturing proteins, the viral proteins. Okay, so if your inflammatory system comes in and ruins the factory, then the enemy will have to leave. Basically gets limited, self-limited. So maybe we do need the destruction of the factory by the inflammatory system. Does that make sense?
Well, viral replication through messenger RNA, our own immune system senses that that's not a human cell. It's viral.
Our immune system does, yes.
That's called the immunosurveillance.
Yeah, I understand, but that takes time. That takes time.
Prevent cancer growth, oncogenic cancer growth, oncogenic.
Yeah, the immune system takes time to respond.
That's why antibiotics would be helpful sometimes.
The inflammatory system responds within hours. The immune system takes days or weeks to mount an effective response against an antigen. But so that's why we have the inflammatory system, right? But the inflammatory system is like your crazy cousin Eddie. It comes in and just does a lot of destruction.
That's what you call the NK cells, the natural killer cells. NK.
Yeah, the NK are the T killers, the TK cells, T lymphocytes. Killer T cells. Any questions?
We have a question from Love Peace on YouTube.
I love peace too.
So
Yes.
she asks, what must a patient present for United Healthcare to agree that DLDR is medically necessary?
What must a patient do with United Healthcare to get United Healthcare to agree that DLDR is medically necessary?
Yes.
That's a great question. You have to get United Healthcare to want to help people rather than themselves. United Healthcare is a business, and by saying that DLDR is not medically necessary, they don't have to pay for it. If they don't pay for it, then they get to keep more money in the bank that they don't pay for the doctors and the surgery. So the more money they keep, the more profit they make. United Healthcare is the #1 profit insurance company in the world for health insurance. They're quarterly, every 3 months, they make $5 billion profit, $5 billion US dollar. That's what they tell us. I think they make more, but they don't tell us. What's going on with irrigation? Are we good? United Healthcare makes around $20 billion a year in profits by not paying doctors' bills. The more doctors' bills they pay, the less profit they make. You see? That's how insurance works. They take all the money from everybody every quarter, every month as a premium. And when you have to make payments to surgery, they lose. So if they pay $100,000 for surgery, then their profit goes down by $100,000. If they pay $500,000 in surgeries, then their profit goes down by $500,000. So every time they make a payment, we're done. Every time they make a payment for surgery, they have to lose profits. They don't want to lose profit. They want to make as much profit as they can. So they want to deny as not necessary. And they do it all the time. As a matter of fact, there's news articles now. If you look on the news, United Healthcare and other insurance companies are denying more treatment than ever before. Literally, some of them deny 66% of the claims. 66%. That's 2 out of every 3 claims denied. It doesn't matter if it's Duke laser disc repair or some other procedure. They don't care. They just want to deny it. United Healthcare will deny MRI as experimental. When is the MRI experimental? We've had MRI for 30 years now, 40 years. How can you say it's experimental? Well, they do. United Healthcare is not interested in making you better. They're only interested in you keep quiet, stay home when you're sick, and don't cost them any money. So I don't know the answer. I think the only way you're going to get United Healthcare to start paying for people's treatment is if you make government regulation that they can not make any profits. Good luck.
We have another question from somebody on Facebook.
Uh-huh.
Is it possible that only you work with that technique and that no one else does it?
Is it only possible that I perform this surgery?
Yes, that's correct.
Yes. It is. It is true. We are the ones who discovered it. I discovered this treatment, pioneered it 17 years ago. For 17 years, we've been doing this surgery, helping people get out of pain.
How much time do you have left?
Oh, I'm done. I was just waiting for you to ask. I'm kidding. It looks good. I'm happy. Is he ready to wake up? Huh? All right, good. Very good. There's the nerve right there. We're just underneath it. Looks good. I'm happy with that. That's the antiseptic we're putting. Hold on. Make sure I'm not leaving anything. Huh?
We have a question from Bobby on YouTube.
Hi, Bobby, on YouTube.
Why so many ALIF, L5-S1 fusion surgeries?
There's a lot of ALIF L5-S1 fusion surgeries because that's the surgery that orthopedic surgeons do. And they don't like to go in the back of the spine. They're afraid of the nerves. The nerves live in the back. So they go through the front. But the only problem is the ALIF is the most dangerous surgery we do. The complication rate is very high, especially for men, because they can have the retrograde ejaculation and sexual dysfunction. The nerves for sex are in the front of the spine at L4-5, L5-S1. So too many people have problems with the nerves after the surgery, and they can't have sex anymore. This is a much better surgery. We don't have that problem. All right. Great job. Any other questions? Ray, take off.
No current questions.
Okay, let's go ahead and end the broadcast. Good job, Sanjay.
Copy that.